Thank you, respected chairpersons. So you've heard me in the morning, and again, Dr. Neeta and Dr. Sanjay had actually requested me to fill in for one of the speakers who couldn't be here for this program, and has requested me to speak on diabetes in young. And I thought I would try and share some of the cases that I have seen in my own clinical practice, and through that patient journey of cases, perhaps try and help you in your day-to-day clinical practice to try and create your own approach into the diagnosis and management of diabetes in young. So the first question that most people would ask is, what do you mean by young? Because I still consider myself young, but I'm still far beyond 25. So by convention, diabetes in young is defined as individuals who develop diabetes before the age of 25. Now, given that if you look at the world population, particularly even if you look at Indian population, 40% of India's population is below that age. Now, whatever percentage of diabetes you have in that particular population, because the denominator is so big, you are going to have a huge number of people who are going to suffer from diabetes in that age group. So even though, type 2 diabetes, which is probably going to be the most common type of diabetes in the elderly population, or at least individuals, say beyond age 30, 35, whatever the causes of diabetes in the younger generation is, even if you look at a population prevalence of 1%, that would mean huge numbers in terms of India's population of 127 crores. So when we talk about diabetes in young, the first diagnosis that comes to everybody's mind is type 1 diabetes, because that's what we were taught during our undergraduate days, that the commonest cause of diabetes in young is type 1 diabetes, which is still perhaps true, but I'll try and show you the other reasons as well. Type 2 diabetes is becoming exceedingly common even in the younger population. Only a couple of weeks ago, I saw a young boy, 9 years of age, with type 2 diabetes. And you have, of course, a lot of other secondary causes of diabetes in young. Now, this is Dr. Mohan's data. If you look at it, over the last few years, the number of people that they have seen in their clinic suffering from diabetes in the young has gone on increasing. Of course, maybe business is doing well, but at the same time, it might well be that actually the prevalence of diabetes in young, as well as the awareness of doctors in diagnosing diabetes in young, might be going up. What's interesting is, if you look at the 1992-95 data, the blue bars tell you that most of the people that they saw for diabetes in young was type 1 diabetes. Now, this data is a little old, but I'm quite certain now you will see that it's more of type 2s that we see than type 1s, particularly if you take an age cutoff of 25. So gradually that proportion of type 1 versus type 2 in the young population is dramatically changing. And what's interesting is, compared to our other counterparts in the same Southeast Asian region and compared to our white Caucasian counterparts, the incidence of particularly type 2 diabetes in India and this part of the globe has increased exponentially. Now that actually parallels the obesity epidemic and the metabolic syndrome epidemic that we are having in the population at large, and so-called affluence and so-called overnutrition has actually probably led to that. What about type 1 diabetes? This is Dr. Prasanna Kumar's data, which says that every 5th type 1 diabetic individual in the world is an Indian. Now, whenever we were taught about type 1 diabetes, we thought, it's the Scandinavian countries which have type 1 diabetes. But because our denominator is again that big, we probably have the second largest number of people diagnosed with type 1 diabetes, the United States being the first. But again, the numbers have probably gone down because most of our type 1s die before they can get counted. So that's probably the reason. And it's estimated that about 1 lakh, the newer data shows about 1,20,000 people with type 1 diabetes in India. So with that bit of epidemiology in the background, let us have a look at a few illustrative cases of diabetes in young. Pooja is an 11-year-old girl who's come for summer vacations to visit her grandparents in Kolkata. Parents actually work in Bangalore. Her grandparents noticed that she's getting thinner, like all grandmothers notice, and has been eating well, but still is losing weight, has been thirsty and has been thought to be playing out in the sun for several hours. One late afternoon, the child actually faints. It's at this point of time that the child is rushed to the hospital, where the blood glucose is 480 milligrams per deciliter. Ketones are strongly positive, bicarbs are low. She's admitted in the ICU and a treatment for diabetic ketoacidosis is started. Incidentally, the grandparents have diabetes. A C-peptide is done, which is low. The GAD antibodies and the IA2 antibodies were done and they are negative. Should she undergo additional tests? Because the father believes in Googleopathy. He's gone and read up that type 1 diabetes is a disease where you have low C-peptide but the antibodies are positive, and has also read that type 2 diabetes might present with ketoacidosis and the grandparents have type 2 diabetes. Therefore, the doctor must be wrong in terms of the diagnosis of type 1 diabetes. This must be a ketosis presentation of a type 2 diabetes. So, he wasn't aware of the fact that there is something called antibody negative type 1 diabetes. Now, there is a lot of publications, including our own data, which is in the process of publication, that at least 40% of Indians with type 1 diabetes are antibody negative. So, that's what is there, and of course, it will again depend on when are you doing the test for the antibody. You know, if you do it at diagnosis, you're more likely to have it positive, and if you're going on checking the antibodies over a period of time, your antibodies are more likely to be negative. So, type 1 diabetes without autoantibodies is a reality, and therefore, please do not start panicking if somebody is being diagnosed with type 1 diabetes but is antibody negative, because it is a very common presentation of type 1 diabetes. So, from there, if you look at the clinical clues in this particular individual, the child was not obese, the child was in fact lean, the C-peptide was low and the antibodies was negative, so it is antibody negative type 1 diabetes. Moving on to the second case is a 19-year-old girl went to the gynecologist for menstrual irregularity. She was asked to do a fasting insulin level, which most gynecologists ask for, which I have stopped doing in my clinical practice, because the clinical parameters of insulin resistance are good enough in most of these PCO presentations, and was started on metformin, which is again being questioned by the American guideline. She had hirsutism and acanthosis, BMI of 29, mother and grandmother both has type 2 diabetes, and then someone in the family suggested, you better go and consult an endocrinologist because PCOD is an endocrine disorder rather than a gynecological disorder. So, we stopped the metformin because doing any tests on the metformin will actually mask the results of hyperglycemia, and after 2 weeks or so, we did an oral glucose tolerance test which confirmed that she was actually already diabetic. And A1C was done, lipid profile and renal function along with liver enzymes was done. Not surprisingly, the triglycerides are elevated and the HDL is low. So, this is essentially pure case of type 2 diabetes. Now, that's one thing knowing that this is type 2 diabetes, but there are several challenges of managing type 2 diabetes in the adolescent period and the young adults. Diagnosis itself is something which a lot of doctors are still not aware of. So, awareness on point of the physician that even in 9-year-old, 12-year-olds, 14-year-olds, 13-year-olds, you will have type 2 diabetes, that's one thing. Role of lifestyle, however much we talk about lifestyle in the adolescent period, my experience tells me, and I think a lot of you will agree, it usually doesn't work, because these kids are very resistant to change in behavioral patterns. Parents are also very resistant. Oral agent failure is very common. If you read the New England Journal paper on metformin, OHA failure with metformin in adolescent with type 2 diabetes occurs much earlier than the adults, because perhaps these guys have more rigid lifestyles and more aggressive disease, and the durability of glycemic control is relatively poor. And of course, there are other metabolic issues including obesity, hypertension, dyslipidemia, hyperuricemia. Now, I'll come to this a little later from our own data, but what we found was, if at presentation of the individual is above 21 years of age, has features of insulin resistance including acanthosis, has preserved C-peptide, has dyslipidemia and raised liver enzymes, you're probably dealing with type 2 diabetes. So, these are some of my kids with diabetes that I look after. I now have a cohort more than 700 children with diabetes. And if I look at that breakup, again, this is a bit biased. I'll tell you why. still you see about 45% of those individuals have type 2 diabetes, and it's only about 20% of the individuals have type 1 diabetes. I have a student who's actually looking at secondary diabetes in E-beta thalassemia, and another one who's looking at FCPD. So those are perhaps selection and referral biases because of that. Usually secondary diabetes, you don't get so many of them. So this is our cohort. This is when we had last analyzed the data of around 500 individuals with the breakup that I showed you. I'll just skip some of those slides. It's interesting to know that even at that young age, some of our type 1 diabetic individuals have developed complications already. With a mean duration of type 1 diabetes of around 7 to 8 years, you still see about 10% have already developed some degree of microalbuminuria, 5% have some degree of early retinopathy, and 5% have already developed neuropathy as tested on the nerve conduction velocity studies. If you go back to what the ICMR registry tells us, that type 1 diabetes is the commonest cause of diabetes in India, but the major problem of the ICMR data is it is dependent on the centers which are collecting the data. These are all tertiary care centers where probably the more difficult ones are getting diagnosed, and then there is heterogeneity between the data between one center and the other. For example, the one in the Northeast almost universally reports everyone with who's with diabetes as type 1 diabetes, rather than actually trying to dig deeper to figure out whether these are other causes of diabetes. So the prevalence, like I said, in type 1 in our study is lower, prevalence of type 2 is higher, and higher age cutoffs that we've used of 29 years, because some of them could not give us very good history, particularly the type 2s, as to when they had developed diabetes. So we looked at some of the data, we did a ROC curve, and this is what we thought of might be useful for clinicians in terms of diagnosis of type 1. So if someone is below the age of 16, has C-peptide which is low, both stimulated as well as baseline, and if the liver enzymes are normal and if the lipids are normal, you're probably dealing with a type 1 diabetes. So I'll skip all of that. Coming to the third case, a 25-year-old man from Nodia has got a job in the Gulf countries. So as only part of that actually did pre-employment checkup. No abnormality was found, otherwise asymptomatic, but was found to have increased body weight. He joined work and then had a significant weight loss. His family back home in India thought, he was far away from home, not eating well. So they said, beta, come back. And he comes back, where there is appreciable weight loss, severe acanthosis. He actually gets admitted straight from the airport to our hospital. This is the gentleman after recovery actually. So you can still see the acanthosis. And his blood glucose is very high, he's acidotic, ketones are strongly positive, diagnosed as DKA, managed promptly, and requires very high doses of insulin. And what's interesting is, in addition to his HbA1c, which is high and very high insulin requirement, he has pretty bad lipids and has raised liver enzymes, which tells you that this is probably type 2 diabetes, or at least there is some degree of insulin resistance and hyperinsulinemia. But when you check the C-peptide, it was very low. So one of the things that might happen is you think that there's glucotoxicity, therefore the C-peptide is low. You treat, get the glucose control done, repeat the C-peptide, and it still comes as low. So this is a relatively rare case where you have a background of metabolic syndrome and a background of insulin resistance, on top of which an individual has actually developed type 1 diabetes. So there is strongly antibody positivity. So this is what we call double diabetes. In fact, this is one of my publications from the UK, where we looked at about 350 odd patients with type 1 diabetes and categorized them into those with metabolic syndrome and those without metabolic syndrome. And we found that individuals who had evidence of metabolic syndrome with type 1 diabetes actually do much worse than individuals who have pure type 1 diabetes. The fourth is a girl presenting with malaise and frequent urination, has put on weight for the last few years, grandparents have a history of diabetes, has glycosuria, and A1C is high. C-peptide is low normal. After a discussion with the parents, the doctor started the girl on insulin. After 4 months, remains on insulin. But what's important is, this individual does not have very low C-peptide, it's low normalish. So when you have such a situation, you think of either it's the glucotoxicity which has caused it, or it's still in the phase where there's going to be further decline and it's going to go into type 1 diabetes, or what's important is in this individual the C-peptide still remained low normal, but the antibodies was positive. So in the adult you have an entity called LADA, in the younger individual you have an entity called LADI, which is the same thing. So having said that, you've got to also remember that there might be biological false positivity of the antibodies. So whenever you are interpreting the antibody test results, keep that in mind. The next is a 24-year-old with very high postprandial glucose, weight of only 36 kilogram, very low BMI, no ketosis, uncontrolled on oral agents. If you do an X-ray, you find extensive calcification of the pancreas. This is fibrocalculous pancreatic diabetes. So not all young individuals, particularly the lean ones, are type 1s. Think of FCPD as well. Screen all young individuals for FCPD as well. Screen family members as well. They usually have low insulin requirement. They often have no requirement of the longer acting insulin because the glucagon response is also gone. They are usually ketosis resistant, and also remember that they are very likely or much more greater risk of having malignancy related to the pancreas. I'll skip some of those slides as well. The next is a 15-year-old girl who goes for a school excursion to Digha, which is a seaside resort in West Bengal, started vomiting, was rushed to the hospital, has an upper respiratory tract infection for 4 days prior to the episode. Blood glucose is high, ketones are negative. She was treated with IV fluids and insulin and sent back to Kolkata. Treated at a corporate hospital in Kolkata, evaluated for antibodies and C-peptide when was told has type 2 diabetes and started on metformin. Her father has diabetes, grandfather has diabetes, great-grandfather has diabetes, and a maternal aunt had type 1 diabetes. Now this girl does not tolerate metformin, has GI intolerance, and was asked to start on insulin. The moment she was asked to start on insulin, she came for another opinion to me. So the weight was at about 75th centile. There was no markers of insulin resistance, no lipid abnormality, no abnormalities of liver function test. So you've got to think of maturity onset diabetes in young. So these are individuals who will have early onset disease where you have the diagnosis at least before age 25 in one, ideally 2 individuals. They will not require insulin at least initially, and they will have measurable detectable C-peptide at diagnosis, and the inheritance is autosomal dominant. Ideally 2 generations, if not 3 generations, have to be tested to be positive. Now having said that, in clinical practice, where would you at all consider testing for MODY? So where you see someone who you think that this is clinically not type 1 diabetes, more likely to be type 2, the individual is lean, yet does not have markers of insulin resistance, is either normal weight or mildly overweight, and has no other metabolic dysfunction like dyslipidemia or fatty liver, there you go for a testing for MODY. I'm not going into the details of the genetics of the testing for MODY. So with all of those 6 cases in mind, when a child comes to you, what do you do in your day-to-day clinical practice in your basic setup? Of course, history is very important. The family history of type 2 diabetes is very important. Family history of MODY in successive generations is very important. The rapidity of onset is very important because it probably tells you the degree of insulinopenia and the likelihood of type 1 diabetes. Ketosis goes more in favor of type 1 diabetes, and a lot of times people would have been diagnosed with diabetes, but they are coming to you as a second referral or a third referral. Try and figure out whether they actually stopped the insulin on their own. If they stop the insulin on their own and they are still alive to have come to your clinic, probably type 1 is ruled out. And what has been the response to oral agents? In the examination, the body weight and the BMI is important. Features of malnutrition, particularly in type 1 and FCPD, is important. Features of insulin resistance in type 2 diabetes is important. In terms of the investigations, whether there is any history of ketosis or acidosis, the lipids and the liver function test and uric acid are actually very useful in diagnosing type 2 diabetes and metabolic syndrome. Some kind of an imaging of the abdomen, particularly to rule out calcification of the pancreas and presence of fatty liver or renal abnormalities of certain varieties of MODY is important. In select cases, go for a C-peptide. Even in fewer cases, go for antibody and MODY testing. So that's a very complicated flow diagram of what I've exactly told you, but that's what I will stop with. Thank you very much.
Thank you. you very much, sir.
Shall we have the
Dr.
questions?
Ajay Ghosh seems to be a very natural speaker. He has had elaborate presentation in the short period with a total command on his topic. And as it was through case-based presentation, it was more practical. I think I would call upon all the four speakers to the dais so that the audience can interact with them. Now the topics are open for discussion. If there are some questions, audience can definitely ask.
Good afternoon, sir. I have two questions to Dr. Sujay Ghosh. Regarding your second patient who saw, I think she was 19 years old. Now, what was your management plan in that patient and also the management plan in the last patient also?
Right. In terms of management of type 2 diabetes in young, I think I was trying to highlight some of the management issues. First is about lifestyle, which is again the cornerstone of management of any type 2 diabetes. It is a challenge in terms of trying to get an adolescent to actually adhere to lifestyle and diet and exercise. I think those of us who actually look after type 1 individuals as well will also concur that a type 1 kid is doing well until puberty. The moment a type 1 kid gets into puberty, lifestyle management becomes very difficult because these children actually start become very unruly. They start comparing themselves with their peers. Why can't I eat a pizza which my friend can? Why do I, and that's the age, between say class 10 and the college years when they're sitting down and studying for their board exams, for all kinds of entrance exams. So diet and exercise is a major challenge, or lifestyle changes is a major challenge when we are looking at particularly adolescent period. In terms of drug therapy, again, the cornerstone would be metformin, because we don't have much of data with the newer oral agents. And if it doesn't work, go back to your insulin, because you don't particularly, say for example, if I have a 9-year-old type 2 diabetes, what do I do? Because everything else is going to be off license because you don't have a licensing for any of those drugs. What is important is again screening for other metabolic parameters like hyperuricemia, dyslipidemia, obesity. Those need to be managed, the fatty liver, all of that needs to be managed, and screening for complications, because these are individuals who will go into OHA failures rapidly. These are individuals who tend to have more aggressive disease. And if you take a family history, you will see almost all of the times both parents are diabetic. And the parents might have developed diabetes at the age of 40s or 50s, but the child has developed it much earlier. So screening for complication again is a major challenge.
Right, sir. And about the 19-year-old patient, the second case. 19 years old.
That's the type 2 diabetes patient you're talking about.
Diabetes.
That's what I was talking about. The 19-year-old is the PCOD.
Yeah, that one.
Which other one do you want to talk about?
In that patient, if the patient is not controlled with metformin,
I would go to insulin.
no sulfonylurea.
I would go to insulin depending on the age.
Right, sir. Thank you.
But by and large, all our polycystic ovary patients who do present with glucose intolerance or diabetes, if you encourage them to diet and exercise and metformin, we are able to control their diabetes, and we don't need to give insulin in them. But we need a lot of counseling in them because
Yes.
they're adolescents and they need to understand. We can't keep blaming them also because the high androgen levels actually increase hunger. So we should understand all that and then counsel them and saying, okay, we are with you and we are on the same side and we are not judging you. Basically, that will make them understand to cooperate with us to control their sugars.
It all depends on the age, ma'am. 20 and beyond, they are much more willing to listen to you. They've got the hirsutism. They've got a boyfriend to, try and say that I'm going to try and tackle this hirsutism. But when you're looking at, say, 12 to 14 or 15, class 9, class 10, it's a huge challenge. It's a huge challenge.
You can't talk to a 12-year-old and say you will get heart attack because
Yes.
for them 25 is like very old and I won't live till then.
Yes.
So you should talk about very near-term goals like
Yes.
you won't look nice in a dress or something like that, and they understand that better
Right.
than long-term complications of diabetes and things like that.
I found your case of double diabetes was very, very interesting.
Yes. Normally when we talk about double diabetes, we talk about a situation where someone has type 1 diabetes as a young adult, then gradually puts on weight and develops other features of metabolic syndrome. Here this case was interesting because, unlike most people in India, this particular individual had baseline data that I could actually go back on because of this pre-employment checkup. So there was everything else was fine, and then suddenly you have this episode of hospitalization, ketoacidosis, low C-peptide, high insulin requirement. So an attack of type 1 diabetes on top of a background of metabolic syndrome. But you've got to remember, when we are treating more and more type 1s, who develops type 1? It's the same population that we are living in. So the population at large has maybe 1/5 to 1/4 of our population has metabolic syndrome anyway. So when we are treating that bit of type 1s, we've got to be much more aggressive when we are treating those type 1s in terms of the statin therapy, in terms of the metformin therapy, in terms of the weight management, in terms of the blood pressure treatment as well, and yet mentally be prepared that that subgroup is probably going to do worse than those without the double diabetes.
Did his acanthosis disappear? Acanthosis nigricans?
The acanthosis did not go away totally, but he lost a little bit of more weight and it kind of stayed. And he was on almost 130 units of insulin for management of his diabetes.
This is for Dr. Boraskar. That Sera is available, sir, and advantages of erythropoietin.
Sera is available to me.
Willingness and little bit of money, we can arrange it. It's available.
Advantages of erythropoietin.
Sorry?
Advantages of erythropoietin.
Advantage of erythropoietin is particularly in erythropoietin resistance as well as deficiency. It's of immense help. I have seen hemoglobin coming up to 30-40% with proper use of erythropoietin. Only thing, when you give blindly that you write erythropoietin 2000 units BD, twice weekly, indefinitely. That is the prescription of most of the nephrologists, which I object strongly. You give it at a particular time, you stop it also at a particular time. No, this advantage of this Sera. Sera is like a continuous supply. Even, erythropoietin, the action will be over in 24 hours. Now, you cannot give every day. You have to give twice a week. So that is a compromise. Sera will act all 24 hours continuously for months together. Sera is a continuous, plus it at the periphery. It has a finer action. Sera is better than erythropoietin, but cost is quite a lot. Yeah.
Boraskar sir, there was one question. You said almost 70% of the patients of type 2 diabetes have stool occult blood positive because they are on some kind of aspirin or some. So in such kind of patients, how to decide whether to go ahead with scope?